Thank you very much, Dr. Ginto. Thank you, Dr. Sameh. Really, it's an honor to share here with and to take us virtually to Egypt. Thank you very much. Hopefully, in the future, it's going to be in person. And I am really honored and humble to share with such giants in world neurosurgery. Professor Tatagiba gave an amazing lecture, which focuses on the importance of taking the most advantage that you can from the retrosigmoid approach, and it's a masterpiece. Also from Professor Goel, it's amazing, all the experience and all the lectures. Professor Sanford Su, also very nice, and Professor Victor Hugo Perez with very beautiful anatomical dissections. Today, I'm going to talk a little bit about the anterior petrosal approach. The anterior petrosal approach, it goes a little bit against, well, not against, but it's another understanding of the pathology in the region, as in the previous lectures has been said. But in a way, the first thing of all, I think that is that we have to be very, very deep knowledge in our anatomy in order to understand the anatomy, to understand the surgical approaches, to understand the different advantages of each pathology. As well as it is important, the pathology, the anatomy, it's also very important to understand how we can help all of these patients which didn't have a good result, and how I can improve my techniques in order to improve for the following patients. This is obviously not a good results, but it's a way of understanding how I can do better in my future cases. For me, it's very important to understand the origin of the tumors, not only to understand the location of the tumor, but also to understand how this tumor grows and how this tumor has a different relationship with neurovascular structures. So it is very important to understand that when we have a tumor in the petroclival region, for example, that this tumor may be, depending on its origin, it can be growing and growing in different regions. And sometimes we have to be able to use different types of approaches according to the need of each patient and according to how this tumor is going to displace the normal cerebrovascular structures. So it is very important to understand and to analyze the origin of the tumor and how this tumor is going to displace the structures. For example, in this case, this is a normal cerebellopontine angle illustration. And for example, in this case, I know that I suppose that this is going to be the position of the cranial nerves according to this tumor, which I saw that it had close to the tentorium. And this is going to be different from the position that this clival, this is a very close tumor, but the growth of pattern of this tumor, I am supposing that it's going to be different, the displacing of the tumors. So if I use the retrosig corridor, from my point of view, it's going to be a different position of the cranial nerves, and that will cause the injury that I am trying to avoid. For example, in this other tumor, it's also in a very similar position, but as Professor Tatagiba showed, this is an acoustic, and so the position of the tumor is going to be, of the cranial nerves is going to be different as compared to the other ones. And this is from globus jugulare, and so the position of each of the same, of different examples in the same region, is going to be different from each other, from the displacing of the cranial nerves. And so, for example, if I use for example, in this case, I use this case, and it's going to be very short because it's not related with anterior petrosal, but the thing is to say that not all petroclival lesions needed an anterior petrosal. There are some that, as Professor showed previously, with an extended retrosigmoid approach, you can easily reach, because I know that this tumor, as Professor Goel also showed, is attached to the tentorium. So I open the tentorium, and there I can see the fourth cranial nerve, and the seventh is going to be all the way down because it's pushing the cranial nerves downward. And so then you proceed with the ultrasonic aspirator, and with careful dissection of the cranial nerves, always preserving the arachnoidal plane. It's very important, as it was showed previously. And when you have the arachnoidal plane, as in this case, it was possible, you can remove part of the tumor, and now you have a wide exposure. And it was all allowed because we removed and we opened the tentorium. That was the key step in this surgery. And now here you can see that everything is preserved, the fourth cranial nerve, and the post-operative, the pre-op and the post-op. And the most important thing is that the patient is without any deficit. But not all cases are like this. So I need to understand the middle fossa. For me, the middle fossa, it's a very, very important anatomy that it has to, you can take a lot of advantages, not only to pathology that it's in the middle fossa, but also to pathology in different regions, in posterior fossa and anterior fossa, and in the sellar and parasellar region. And so in a way, this is kind of a universe if you explode it and you take the most advantage that you can from this pathology. How do we do it? With a normal pterional approach, as it is shown here, with an extradural dissection. Sometimes you can do clinoidectomy, sometimes it's not needed. But the thing is that when you do the peeling of the middle fossa, then you can do the extended middle fossa approach, that is using the posterior medial triangle and drill it away and explore and exploit and expose completely the skull base, the skull base in the region. And so in a way, when you do this approach, you have different regions that you can go. You can go from the roof of the infratemporal fossa, parasellar region. You don't have to do all of this, but it's part of different phases that you do according to the region that you go. As in this case, we are talking about the anterior petrosal approach. We have to honor Dr. Kawase's paper about this, and it opened and visioned the pathology, the approach in order to improve it. And for example, in this case, we have a small meningioma in a 60-year-old patient with trigeminal neuralgia. An option would be, as it was previously mentioned, you could do a retrosig approach and open the trigeminal nerve and free it. You can also use different approaches, as I was saying in the previous case. But the thing here is that you can see here that the tentorium is infiltrated, and the tentorium it's infiltrated with tentorium. So if you go from below, I think that it's going to be more challenging in order to remove that tentorium and to clean up that trigeminal nerve, which is causing the trigeminal neuralgia. In this case, what we do is the middle fossa approach. This is the way that we do it. We the root of the zygoma, we can cut it in order to have the muscle, bring it below, and this is more or less the craniotomy that we use. This is the case, and it's very important to do a step-by-step dissection. It's very important to try to identify, not to try, you have to identify here the middle meningeal artery. I like to cut it halfway because this happens when you don't coagulate it completely, and now you can coagulate it completely, and then you finish the cut. Okay, so it's very important to complete the dissection in order to take all of those take care of those risks. Now we are dissecting B3, as it is shown here. We have now we are exposing the posteromedial triangle, as it is shown here. It's very important to identify the trigeminal impression. We find it that it's very useful. Identify the GSPN, the trigeminal impression, the arc with eminence, and now here we have an exposure of that it's similar to what we've done in our cadaveric lab. And the thing is that now we can proceed identifying the structures. Very important. I'm going to go a little faster. Identify, we know that the GSPN is going to be the reference for the carotid artery, and continue the dissection and continue the anterior petrosal approach. In this was one of our earlier cases. And so, for example, it's very important, I'm going to understand that we have to expose completely the trigeminal nerve, as in this case, that it's causing the trigeminal neuralgia. So we open the dura in the middle fossa, and this is the part that I was talking previously, that we see that all this tumor, it was as you can see here, you can see healthy tentorium and infiltrated tentorium. And so this would have been much more difficult to reach it from below. And so in our way, we think that this is easier to remove through the middle fossa, the extended middle fossa approach. Now we continue, very important to continue opening the tentorium all the way down to expose the fourth cranial nerve and to remove the tumor. And once we have the tumor, we can remove it in a piece, as it is shown here. And we can see here now that we have the trigeminal nerve. And so we continue with the cleaning, and this was the result. And the patient got solved with the trigeminal neuralgia. This is another case where you can see that it's very upfront from our point of view to the anterior petrosal, and it's also one of our earlier cases where, in the same way, we exposed the posteromedial triangle and we drilled the Kawas's triangle. We exposed. By that time, we were learning that it was very important to expose completely the trigeminal nerve and to have a wide dissection, and to have a wide dissection and to take advantage of the trigeminal nerve, and to have a medial and a lateral dissection. And so that could allow us to continue to have a better exposure. And so when we have the trigeminal nerve completely exposed, then we continue to opening the tentorium, as it is shown here. And we can see that now we have completely exposed the trigeminal nerve, and we can see the brainstem, and we can see the tumor completely. Okay, and so we have a wide exposure of the tumor. Okay, now using ultrasonic aspirator and microsurgical techniques, we're going to continue debulking the tumor. And this way we can continue. There we saw the fourth cranial nerve, which is always going to be very close, has a close relationship, or sometimes adherent to the tumor, and so we have to be very careful about it. we can use, this is something I really think it's a great advantage, that we can use and mobilize the trigeminal nerve in order to expose completely the tumor. And so there we are working medial and lateral to the tumor, as we can see here. And there we are exposing completely the tumor. We can see that we have identified the fourth cranial nerve. We can see that there's some tumor that we are trying to clean up in this medial close portion of the clivus. And there we identify that we preserve the fourth cranial nerve without a problem. And that's the exposure. And then all of a sudden we have this MRI. And for me, this is it's not a good thing. Look, we have a residual here. We have a residual in the medial part of the. And so for me, at that moment, I am really frustrated that even though we tried to improve the best approach that we could, we are not happy with the result, because we know that we are leaving back a part of tumor which can be watched, but we have to be honest with ourselves and criticize ourselves in order to try to improve. And what do? We go back to the lab, we go back to our mentors, to our friends, and try to do and understand how we can improve better. Then we have some other cases where there's a good advantage in these trigeminal schwannomas, so that it's an open highway to remove the part in the middle fossa and also the posterior fossa. But that brings us to the understanding and studying with our fellows, studying the anatomy, and now in our lab in Mexico City, that understanding the anatomy and how we can apply the knowledge of the lab and apply it to our cadavers. Very important to our cases. I'm sorry. Very important to all understand all the relationships, either from the skull base, but also the relationships from the cortical, in order to the deep understanding of the anatomy, and understanding the temporal bone, which is crucial for example, of one of these cases. In this case, it was a very complicated and difficult decision-making case, because it was a patient which had very few symptoms. And so in a way, we were trying to think which of all of the approaches we could take the best choice that we could get for this case. And at the end, we understood that improving this anterior petrosal approach is taking the most advantage that you can in these cases. For example, going to the lab is very important in order to understand the relationship with the trigeminal nerve, to understand the limits of the 7 and 8 complex, and also to take advantage the most that you can, exposing the carotid and putting in the endoscope in order to identify the 6th cranial nerve, the lower cranial nerves, and to understand. And so this way we can combine the anatomy learned in the cadaver lab and now going to the OR. And so in this case, we did a combined Petrossal approach. We were thinking that we would also need I'm sorry for the noise. Here we are exposing the trigeminal impression. This is the posterior-medial triangle of the middle fossa, the arcuate eminence, and we are doing there. We started with an anterior petrosal approach, doing the drilling and drilling lateral and also medial in order to expose completely the trigeminal nerve, to have the posterior fossa widely exposed. We combined it with a posterior petrosal approach, which I'm going to show later what was the advantage of it. We opened the tentorium, and very important to open it all the way and taking care to have a wide open of the tentorium. As I was mentioning previously, this mobilization of the trigeminal nerve is what I find really, really useful, because in this way we don't have to mobilize or to injure the facial nerve. And so in this way, we have a very wide exposure of the complete between, we're trying to dissect there the trochlear nerve, which was very adherent to the tumor. At the end, we lost it, and we decided to take care of the nerve because it was very adherent. We could not save it at that moment. And we have now a very wide view of taking the most advantage that we can of the posterior fossa. And there in the posterior petrosal, we see that the space was very narrow. So there was no way that we could have taken a good advantage from the posterior petrosal without injuring the cranial nerves. And there we are removing the tumor. We reconstructed the fourth cranial nerve, and that was the pre-op, the post-op. That was the result with the patient, the pre-op, the post-op, with the residual of the implant there, and our patient in the immediate post-op, and then she improved 3 months later. She had a facial palsy, as you can see here, but she recovered fully. This was 6 months in the post-op, and the eye movements after 6 months with a great improvement. And so this was what we learned in that case. This is another case of a young patient, 40-year-old, without any symptoms at all. So it's difficult because you have to offer the best option that you can in a patient asymptomatic and with such a giant tumor and a young patient. And so in this case, we have a great compression. And an important thing for us is that, as you can see here, we have a pneumatized apex. And so what do you do with a pneumatized apex? Either you decide to go in a retrosig with the possibility from our point of view to injure the cranial nerves, or to take advantage and reconstruct here the pneumatized apex. That's a dilemma that we were. So what do? We go to the cadaver lab, and this is what we try to resolve in that issue. We go to the cadaver lab, we do the way that we do our approach. Very important to know that we are going to reconstruct and use this use this pedicle flap in order to reconstruct and then to complete the approach. And very important, going from the lab, okay, very important, and then going to the OR and doing and mimicking exactly the same surgery from the lab to the OR, and so we can get the most advantage that we can. So later on, this is the incision that we decided to do. We are exposing here the combined petrossal, the craniotomy, and this is how we do it in our lab. And we continue, and very important to have a wide exposure with the posterior petrosal approach. Then we are dissecting the middle fossa. Very important to identify as I said previously, the middle meningeal artery in order to expose and do a cavernous sinus dissection from backwards to forward. Okay, and so there we are. We are exposing the middle fossa, the Kawasa's triangle. We have the trigeminal nerve, the trigeminal impression, and there we can see the pneumatized apex that we were talking previously. We had to open it, but in a way we were prepared with our pedicle flap, and so we try to take the most that we can. In doing the anterior petrosal approach. Okay, then we finish the posterior petrosal. Very important to identify the landmarks and to know that this is going to be the position, the way that we open the dura, in order to open it from the posterior fossa, to open and sectioning the superior petrosal sinus and opening the tentorium. And then following, as we said previously, the opening of the dura. There we can see that we have the tentorium. Very important to open widely all the way to the free edge, the tentorium. And there we can see that we have the tumor, we have the normal cerebellum, and there we can open the dura all the way opening to the anterior petrosal approach. Very important, as we said previously, it's very important to liberate and to unblock or liberate the tentorium. That is the trigeminal nerve, and that's going to be very important in order to mobilize it and to have it freely. As we can see here, the 7 and 8 complex, as you can see, it's in the lateral part of our approach, so we don't have to handle it at all. And so that gives us an advantage according to the retrosurgical approach from my point of view. There we are seeing the 4th cranial nerve, which was also very adherent. The 6th cranial nerve, we did some debulking. And we continue there with removing the medial part that we learned from the previous case. And there we have the basilar artery, all the adherences. And there we can see that the 4th cranial nerve is preserved. There was some arachnoidal attachments there to the brainstem, and we reconstructed with a piece of muscle with some duragen, and now with the flap we face it, and then we put a little bit of fibrin glue, and that was the reconstruction that we did in that case, which was something that was worrying us. This is the post-op result. It's a good removal for this patient. This is the immediate post-op. We can see that she has a 6th cranial nerve. She doesn't have a facial palsy, but she has a 6th cranial nerve, which after 3 months she completely recovered. And this is the post-op. So at the end, my conclusions are, as I've said previously, microsurgery is the essence of neurosurgery. So it is very important to apply all the surgical techniques, all the microsurgical techniques that we've learned from our mentors, and apply it to different surgical techniques that we use today in skull-based. I cannot say something else, but lab. It is never it's enough working in the lab. So it is very important to always continue, never stop asking questions to yourself, and always looking for answers. I find it that teaching and looking for these answers together with your fellows is the best learning for everybody, for you, for your fellows, for the patient, for everybody. And so it is very important to always give your best effort for your patients, and always work up with your team, find your teamwork and do a good teamwork. This is our manual from our skull base that we are doing, made by our fellows. And always very important, follow your passion, always look and be surrounded by people who have that same passion, and always with a good result. And so this is our teams of fellows, and thank you very much.